Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Mariel Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Hi, I'm Dr. Clint Flanigan in the Boulder, Colorado area. And DPC to me, it means so many things, but if I were just to boil it down, I think it's important for people to know that direct primary care is a model of care that's arguably the best model of primary care in this country, and that it was started by physicians that had worked in a fee-for-service system and said, gosh, we need to do better, not only for our patients, but also for physicians so they can remain independent and perhaps own their clinics if they'd like to. While many things can be said about DPC, I just think it's really important to know that physicians created this model because we needed to do better than the existing model. I'm Clint Flanigan. I'm a family medicine physician in Colorado, and this is my DPC story.
Dr. Clint Flanigan is the founder and CEO of Nextera Healthcare. Nextera Healthcare is Colorado's first direct primary care program, established in 2009. Nextera Healthcare members are assessed an affordable monthly membership fee for unlimited office visits and virtual consultations with physicians at North Vista Medical Center and affiliate medical practices. Nextera Healthcare was selected by Fierce Healthcare out of hundreds of healthcare companies across the world as one of the 2019 Fierce 15 companies and has been designated as one of the most promising healthcare companies in the industry. Nextera Healthcare has established a community of over 100 clinics throughout Colorado, Maryland, Michigan, Nebraska, Iowa, Florida, Virginia, Wyoming, and the Washington, D.C. area. Board certified in family medicine, a diplomat of the American Board of Family Medicine, and actively practicing physician, Dr. Flanigan has been a fixture in Colorado healthcare for over 20 years. Dr. Flanagan has been named one of the top value-based care thinkers in 2022, was named to the top 20 of who's who in the direct primary care in the U.S., and was invited in 2019 to be a founding committee member of the Direct Primary Care Mastermind Initiative, focusing on serving employers. Dr. Flanagan graduated from the University of Nebraska Medical Center and completed his residency at St. Mary's Family Medicine Program in Grand Junction, Colorado. In addition to working as a family medicine physician, he has 15 years of experience as an emergency physician working in many underserved communities throughout Colorado and as far away as Iraq, where he served as an officer in the Army Medical Corps. An accomplished healthcare visionary, Dr. Flanigan regularly contributes to policy discussions at the state and federal level to ensure physicians and healthcare providers have ample opportunity to deliver high-quality, affordable, and accessible care to families and businesses. He has testified on behalf of DPC and has been directly involved in DPC legislation that passed unanimously in Colorado and Nebraska. He sits on the steering committee of the National Direct Primary Care Coalition, and during their June 2014 Washington, D.C. conference, he was invited to discuss DPC at the White House. He has also been invited to present his insights on the emergence and implementation of DPC to a wide range of groups, including medical students, residents, and professional associations. His free time is spent enjoying his family and outdoor pursuits in the Colorado Rockies. Welcome to the podcast, Dr. Flanigan.
Hey, Mariel, nice to see you.
This is such a treat because, we've been on stage in the past couple of years and have a little bit of a background hearing your story in little bits because we've been on stage together talking about DPC. But I also, love, and people probably don't know this, that you were born and raised in Nebraska. Like, I always love pointing that out because people from Nebraska are my people. And you went to medical school with Dr. John Jacobson, who was formerly on the podcast. He is practicing in Kearney, Nebraska. And then Dr. Julie Tice, who's another medical school classmate of yours, was my former attending in Superior, Nebraska. So again, welcome to the podcast.
Thank you so much, and very much looking forward to this. Yes, you're right. I was born in Nebraska, grew up there as a kid, did my undergrad there, as well as a bit of HIV research and some grad school, then went on to med school there. And yeah, I met Dr. John and Julie. And yeah, lots of good things come out of Nebraska.
Awesome. I'll make sure that Dr. Amber Beckenhauer replays that also, so she'll love it. So let's get back to your roots in choosing family medicine. When you went to medical school, did you decide early on that you wanted to be a family medicine physician, or did that come later in the third and fourth years of medical school?
Yeah, so I had experiences as a kid, including surgery on my knee when I was a ninth grader, I believe, in Nebraska. And so kind of had a patient experience there. And then throughout my childhood years, had just really good primary care experiences with physicians in the small town that I grew up in. And I would say that's where kind of things, let's say, started. I didn't have any physicians in my family, although I had some friends that had, a parent that was a physician. And then early on, I think it was in high school, I got in something called the Explorers Club. And the Explorers Club allowed us to kind of, let's say, pick something we were interested in and explore. And in that case, at the local hospital in Fremont, Nebraska, as a high school kid, got to learn more about medicine and hospitals. And through that, really further solidified my interest in medicine. And so I would say as I went into med school, I wasn't 100% sure what kind of doctor I wanted to be. I just knew for sure I wanted to be a physician, and explored a number of things ranging from emergency medicine to OBGYN to primary care to rheumatology. And it was kind of probably through the earlier clinical years, especially I did a rural rotation. So as a younger med student, you're able to spend some time in a rural community. And boy, I sure enjoyed everything that primary care clinicians could do. I don't know that, there would ever be a boring day. That was kind of my idea that I had as a doctor in training. And as time moved forward, and now, reflecting back on 20 some years as being a family medicine physician, there's never a boring day, or there's never monotony.
I love it. And totally, those experiences of being in a rural location when you're in medical school, it's incredible. I remember my husband was told by the medical student who had rotated in Superior before he went out there that he needed to get new shoes, because if he was going to follow Dr. Tim Blake and Dr. Julie Tice, he needed to walk fast. And so I think it's so special that you were able to see what a true family physician can do when they're given, a community that loves having a doctor that knows them. It definitely gets a little dicey there, over time when we throw fee for service in the mix. But I love that was what you experienced going into becoming a doctor and the doctor you are today. So let me ask you, when you graduated residency, was it then that you moved to Colorado, or how did you make your way out to Colorado?
Yeah, so like a lot of Nebraskans or Midwesterners, we coming to Colorado as a youngster on vacations. And so doing all kinds of things from going to the Royal Gorge to Seven Falls to hiking in Rocky Mountain National Park. I think when I was 15, I climbed Long's Peak. And so as a flatlander from Nebraska coming out to this utopia of Colorado, it sure had an impression on me as a kid, and continued to come out here skiing and camping and those kinds of things. So when it came time to pick a residency program, my wife and I, her name's Deirdre, who's also from Nebraska, we kind of said, gosh, do we want to stay in the Midwest here, or where do we want to go? So I did, in my last year of med school, I did some rotations. I spent some time in Austin, Texas, spent some time in Greensboro, North Carolina, spent some time in Kansas City, and then also spent about a month at the St. Mary's Family Practice Residency Program in Grand Junction. And again, all fun places and great programs. But my number one choice was Colorado. And I believe I went to the National Residence Symposium that they put on in Kansas City. That might not be the exact name, but in short, there are a lot of residency programs there. In figuring out, gosh, where would I potentially like to go and what type of residency program would I like to be involved in, that was another huge draw for me to St. Mary's, because St. Mary's is a community-based residency program, so there are no other residents. And I think at the time that I went there, around 90% of the residents that leave that program go into small towns. And for me, that was super appealing. And with that came, let's say, a level of training that would prepare you for about anything, right? Including the residency program was pretty high. A lot of training in the hospital and the ICU, as well as a lot of OB training. there was definitely a point in my career where thought I was going to be doing OB, so I was getting lots of deliveries as a resident. So yeah, for us, as we made that decision, not only was the location very important, but it was important for us to be in a community-based residency program and have essentially the ear of our mentors and colleagues that were training us, and we were the only residents in town, right? So it kind of makes a difference versus if you have other types of residency programs in your training.
And I definitely put a shout out to those people who are, applying to residency programs or thinking about, should I do an opposed or an unopposed? It's definitely something to think about because, we've heard from other physicians who have trained in rural programs. An example is Dr. Phil Hellman out of Michigan at Paradox Health DPC. There is a true difference between when you are the only residents in the hospital and when you are one of many specialties in the hospital. So definitely just want to put a shout out there. Now, when it comes to your time in the Army, how did that fit into your residency and your position as a fee-for-service private physician in Colorado?
Yeah, so I got into the Army when I was in med school back in Nebraska. And I come from a family where almost all the men and some of the women family members, both at my parent level as well as grandparents and then beyond cousins, et cetera, had spent time in one of the services, whether it was the Navy or the Air Force or the Army. And as I was in med school and kind of looking at my debt, I wanted to be a bit more proactive. So I was looking at options, all kinds of options, from rural repayment programs to the military. And a friend of mine was in the Army National Guard while he was in med school. He was in an MD PhD program. And so that's where I got to exploring it and really thought that, it would provide me a pretty tremendous opportunity to not only serve our country, but also to be in a place where I could get some training that I might not otherwise get in the civilian world. And then it was also, let's say, conducive to being a student. So that was maybe my second year or so of med school. So I still had a lot of training left. And they had a program that required an 8-year commitment. And so what happened is in typical National Guard fashion is, you spend a weekend. In my case, I'd go to Lincoln and then you do a week or two of, let's say, AT or annual training and just work that into the med school schedule. And then as I moved out to Colorado, I transferred units and went to a pretty cool medical unit in Montrose, Colorado, where we did some fun things like, airplane crash rescue. So I was with a medical unit that gave us some training that, you typically wouldn't get in a civilian world.
Now, how did that work for you? Because for those people like Dr. Jenna Silikowski who've been on and they were in the Army and then they bought their DPC. I don't actually remember when Jenna went into the military, but for you, when you were in the Army National Corps during medical school and then also during residency, how did that work with your training program? Did you have to take off a certain amount of time and then extend your residency so that you could do your service while a resident?
Yeah, so at least at the time, fortunately, I would say both on the training front with regards to med school and residency, as well as the military front, there were flexibilities, right? And scheduling where you could make it work, at least back when I was moving through. So with the Army National Guard, I'd leave Omaha and then go to Lincoln, an hour away, and do some training with the medical group I was part of. And with that, they kind of, in general, put you in with a medical group versus, let's say, the infantry, right? Because they want to put your skill set to use. And then that would happen once a month where I'd go down for that weekend training. And then as you fast forward into, let's say, AT, I was able to work it out with my electives where I believe I was pretty involved in wilderness medicine. So I did a wilderness medicine AT on Jackson Hole, Wyoming. And I want to say I was a third or fourth year med student at the time. So that worked out pretty well because you're on a medical student budget. And yet you can go do this wilderness medicine course in Jackson Hole, Wyoming, and mix in some nature with a little bit of training with really cool guys that know a ton about wilderness medicine and emergency medicine. And that was part of the annual training experience with the military, right? So that, let's say, accounted for me hitting certain criteria. And then as you fast forward into residency, same kind of thing. In fact, my last year of residency, I worked it out where I did my annual training in Oahu at Schofield Barracks. And so as one of my electives in residency, I and my wife Deirdre at the time, and we had a daughter at the time, went to Hawaii. And I did my elective while I was essentially getting paid as a resident and then also got paid because I was fulfilling the requirements of the Army National Guard. And I'll never forget my mentor in residency. His name was Dr. Sherman Straw. Sherman was like, Flanagan, what are you doing again? Like, you're going to Hawaii for a month rotation to do medical care, and you're getting paid for that? I'm like, it's my electives, right? Like, you could do electives as your third year. So that worked out super well. So when I said, it kind of afforded me opportunities that I might not otherwise would have had, that was one of them. And great training at Schofield Barracks, and got to see a bit of Tripler and do some things in Oahu that I would have never probably had done just through my regular residency program, right? And then with that, there was also loan repayment that started kicking in when I was a resident, which was very helpful.
That's awesome. And, again, just talking to those people who have not yet finished residency, it's definitely something to look into, because there's lots of opportunities to craft your electives the way you want to. So I think that's awesome that you crafted your residency elective so that you could be in such a place. I think that's super awesome that you were able to get paid like you did for being in that experience. But also, for those people who are wanting to do things like go to conferences or pick up certifications, do phlebotomy skills, whatever, like think about, in residency, you really have a lot more time, I feel, than in your own practice, whether you're in fee-for-service or you're opening a DPC, to do more exploring. And it's also typically cheaper if you do things as a medical student and as a resident versus when you're a new grad. So definitely things to think about for those listeners who are out there, who haven't yet graduated residency. So with that, now you went from all of this experience to working in fee-for-service, and you were with a multi-specialty group for quite some time. So tell us about that experience, because, for someone who has this broad range of exposure, wanting to stay in Colorado, get that. But how did you pick that particular clinic to work in, and how did that change over time?
Yeah. So, while you're a resident, like in your second year, usually, sometimes your third year, you're saying, gosh, what do I want to do after residency? So we were in that lane, and we knew in general that we wanted to stay in Colorado. We were on the western slope in Grand Junction, loved it, loved living there, but all of our family in general was back in Nebraska. So we wanted to move a little bit closer. So we started looking really from Colorado Springs all the way north up through Denver into the Longmont Boulder area, and then up to Fort Collins. So I did some rotations, including my third year. I spent, I think, about a month in Fort Collins with a family medicine group called Associates in Family Medicine. Great group. And there was a Nebraska doc, Dr. Nevervee, that had worked there. So kind of falling back on Nebraska ties, and spent a month there working. And then we explored the Front Range, Colorado, and knew that's kind of where we wanted to land. And then through another colleague who I think I had connected with, I was serving on the Colorado Family Physicians Board as a resident. They were working with a group in Longmont, Colorado, that was about a 50 doctor multi-specialty group. So through some conversations there, I found out that they were hiring and actually building a brand new office in a small town. And so that was super appealing, that I could move into a new office that was in a small town. And that small town here in Colorado had never had a primary care clinic. So this was, think of it like a satellite office of the mothership. And essentially, I had the opportunity to be hired along with another couple of docs, including a pediatrician. And we would be that small town's first clinic. And then I would come on essentially as a physician, and the compensation and benefits package was nice. And moving into a group that was all owned by doctors, and having the ability to have a partnership track where, I could eventually become a partner for a couple of years or so. And so that seemed to me very appealing. Plus kind of had the safety net of, just from a compensation work perspective, of having a lot of doctors around me for support. There were a lot of offers at the time, but for me, I wanted to be in a physician-owned group. And so that opportunity came up and went forward with it.
And, it still continues to be a very attractive option for people. I was just talking to third-year residents from my former residency who were, they didn't know about DPC at the time, but one of them, I think, went to a practice where she was buying in to be a partner in the Bay Area. And then when I was in residency, the class above me, or two classes above me and the class below me, they went into practices that were physician-owned, where you could be a partner. And I definitely would say that is still a thing. Like as we talk about fee for service, and when we talk about, corporations owning physician clinics and, contracting physicians as employees, there definitely are options still where there are physician owned clinics. So it's definitely something to look into, especially if you're considering like maybe DPC in the future, but for right now, fee for service, it's definitely still a thing. So when you talk about it being physician owned, and when you talk about, really embodying this full scope, small town family doctor in your area and being the go-to clinic for your population, your community, how did it change over time to make you start thinking about there's got to be a different way to do medicine?
Great question. So coming out of residency and super excited about, moving to a new town. My wife and I had built a new house, and we're building our family with my new daughter, Kira. And just, you're kind of a greenhorn resident and moving away from working 100 hours a week or 120 hours a week back in the day. They didn't have parameters on 80-hour work weeks with us. It just really ready to be a physician in that setting. Residents typically graduate like in June timeframe-ish. And so I got a call to duty letter from the Army, I want to say maybe in July, August, right after residency, to go to Iraq in October of the year that I graduated from residency. And so you can imagine, we're moving to a new town, meeting new people. Our clinic technically wasn't finished yet, so we're in a small clinic right downtown, this small town. Myself, pediatrician, some staff, and that was about, let's call it August. And then in October, I went to Iraq. And so I had, let's say, a couple of months of experience, but this was a clinic where there were no patients because we were brand new. And so, the pediatrician Wade and I would joke, we could go have like an hour or two lunch and then work out for 2 hours. And it was so much fun. Meanwhile, while we're salaried, and obviously we wanted to build a clinic. And by the time I left, I was seeing, 30 patients per day. But it was just a lot of fun as a small town, new physicians, getting to know everybody. We'd go out to lunch with the mayor, and then we'd go out and, connect with the people that own the golf course, and then connect with the local banker and connect with townspeople. And it was just, it was kind of like, let's say, what you might envision if you're moving to a small town where there never was a clinic. So a lot of this, let's say, small town romance or whatever you want to call it, right? Where, just excited to start seeing people and taking care of the community. And this is the kind of thing where we're literally on the front page of the paper. The paper was called The Farmer and the Miner. The editor was actually my patient. In that same paper, I remember there's a picture of me and my daughter Kira, and the headline was "Doctor Goes to War."
Wow.
So really, got to embrace this community, live there, and came back from Iraq in 2005, and then started practicing and just really excited about taking care of people in that community. And then, very quickly you start to learn, or at least I did, about just a bit of the business of medicine and this weird billing and coding stuff that you have to do, and you just do it. And at least that's what I did. And I'll never forget, my favorite person was a gal that worked in the coding office for the multi-specialty group. So I learned so much from her because I that's the way the business is handled. And so when you're seeing 5 or 10 patients a day, that's one thing. But when you start to see 25 to 35 patients a day, you really have to become quite experienced at the billing and coding piece. Otherwise, it can really occupy a huge chunk of your day. And usually most of us just want to take care of people. So learned a lot about that piece. And then with that, very quickly found that, gosh, there's got to be some different options when it comes to providing care for people. So that's what kind of led us down a pathway of, how do we better do this?
Yeah. How do we do it better? For sure. And that's, like you said, and we're alluding to the journey that you've taken through Nextera Healthcare, but it's so interesting that when we talk about numbers, right? We hear these numbers like 30 to 40 patients a day, and you have how many people on your panel? And then people very frequently in DPC talk about how many do you see a day? What percentage of patients do you see on your panel per day? And even if we look at 1%, it's okay, 1% in a DPC practice versus 1% in a fee-for-service practice that is pumping out people, visits 35 to 40 a day. It's that's how you get 3,500 to 4,000 people is if you have that many people and you're seeing 1% of that population, I put those numbers out there just so people can see the stark difference between 1% of 4,000 versus 1% of 600 is a very different number of patients that you see per day. And so, when it's something that I was thinking about, if you can't get during an interview at a fee-for-service place, like how many people do you have on your panel? Because like, for example, I know physicians who they can't get that information from their corporation. But if you ask a person like, how many people do you see a day? And you can do the math backwards. Like if you see, assuming 1%, this is how many people they approximately have on their panel. It's another way to interview a place if you're looking in a fee-for-service position before doing DPC. You know, there's all these things that I learned as a DPC physician that I could have asked something about, like, for example, how many physicians have stayed in this area over the past 7 years? How many family practice physicians have stayed in this area over the past 7 years? There's things that I look at now that I'm like, I wish I would have asked those questions before, but hindsight is 2020. So with that though, I wanted to ask about your salary, because when you started and you're on salary, even though you're coding, because that was very much how my journey was, it was like, you show up, you do your codes. However, you're still getting this magic salary. So it doesn't actually matter what you code at the end of the day. Did you transition from salary to RVU production at a certain point?
Yeah. And sorry if I confused you there, but we had our base salary and it was productivity on top of that. So yes, that's why I wanted to become a master of coding, because that's how I was paid.
Gotcha. Yeah.
And so we had, as a multi-specialty group too, we also had some ancillary services. So we had an ambulatory surgery center that essentially all the partners shared profit in. We had an imaging center, MR, CT scan, mammography that we shared profit in. And so you're, a multi-specialty group with a CFO, and those were lanes that primary care clinicians could share. Those lanes would impact our compensation, is the short. So yes, that's why I definitely became very familiar with, what's the payment between a 99213 and a 99214, and, understanding the details of your 10 to 15 to 20 different insurance contracts, like all this stuff that you don't really get much insight into when you're a med student or a resident. And you come out into it and you're like, wow, who designed this? Who designed this? Because it's getting in the way of my patient care. It's getting in the way of my family time.
Well, like you said in one interview, how you were tired of, you became tired of looking in the ear of the insurance person who was then looking at your patient with no actual care for what, their health was. They just saw codes. So, it's something that the people who are listening to this podcast are very familiar with, sadly, but, we are all changing the culture in America. So love it. Now, when it came to you, working in this model of base salary, fee for service, production, being a part, working towards partnership, getting a cut of the profits that were made at the imaging center, et cetera. How did you decide not only there should be a different way, there has to be a different way, but how did you decide to transition into the direct primary care space?
Yeah, so there were a couple of chapters there. And one of those is I was part of that group that really, when I started with them, I really thought that was going to be the job for the rest of my life. And about 2 to 3 years in, just started getting concerned about the way administration was handling things. And the short story on that is, within a period of about 2 years, 20 of the 50 partners left that group and some of them were neurologists, some were orthopedists, and literally walked across the street to a certain extent in town, had a non-compete, wrote $100 and some thousand check, and started practicing as a orthopedist or started practicing as a neurologist. In my case, the street was a little longer because I went 15.1 miles away, which was my non-compete, and literally put up a clinic 15.1 miles away. And so kind of had that experience. And at that time, I joined Colorado's largest healthcare system, Centura Health, and helped them establish a clinic in the North Metro area. So that chapter is important to bring up because, again, this is me coming out as a resident, thinking I was going to have my forever job in a brand new clinic in a small town. And I didn't leave that job because I was dissatisfied with the compensation. I had a really good compensation and benefits package. I left it mainly because I was concerned about the way administration was handling things, and I wasn't the only doctor. And so during that time, I continued to do emergency medicine. So back in the day, us residents would moonlight in small town ERs. And so I started doing that as I think a second year resident into my third year, and then continued on doing working in emergency rooms in small towns here in Colorado. And that was kind of giving me this other lens right, of the, let's say at a high level, the dysfunctional healthcare ecosystem. So in the ER, and half the patients coming through are non-emergencies. So having that experience, and then the experience as a primary care clinician, and then as well working for Centura, largest provider of healthcare in our state for a couple of years, it just really kind of got me to thinking of, gosh, can we do care a different way? We're going to do the care that we want to do with a different model of business. Because the existing model, I'd had enough experience in it that I'm like, I can't do this for the next 20 to 30 to 40 years of my life. I can't. There's got to be a better way. So I had kind of enough experience that led me down to a lane of, I got to do something different.
And then bring us to your fateful year of 2009 when I believe that was when you met Dr. Garrison Bliss. So tell us about that meeting. And as I think about all of the people learning about DPC and starting DPC, and they're like, tell me about this. Tell me, how did you choose your EMR? I wonder what that conversation was like, because DPC didn't have a Facebook group back then. DPC didn't have laws back then, So tell me, what was that conversation like, and how did it really codify your path forward into great, I have, this experience with fee for service. I have this experience with, being a pioneer in bringing care to communities, and then deciding to use that knowledge and go into DPC.
Yeah, so I'm so thankful that I met Garrison. So thankful. So back in 2009, I had started North Vista Medical Center. So I had left Centura Healthcare amicably and had the opportunity to open up my own medical center. So I opened up North Vista Medical Centers, which was a fee-for-service practice. And then simultaneously was thinking about doing primary care with a different business model. And so in the early days there, we just called it monthly membership medicine because we did not know what DPC was. There really wasn't much of it at all in the country in 2009, outside of maybe Garrison and maybe a few others, and moved forward with our monthly membership medicine model. So we had our name, we had logos and marketing material, and mainly who we were advertising to were our own patients and saying, hey, listen, we're going to do this monthly membership medicine. It's $99 a month, unlimited care. Connect with us at any time. Meet you in the office after hours, etc. We'll take care of you, and there's no copay or bill. Just pay that, proverbial gym fee. So we were down that pathway. And at the time, I was a member of the American Academy of Private Physicians. So AAPP is no longer around, but in the AAPP was a lot of docs that were independent docs, and a number of them were concierge medicine docs. And so very much involved in that. And the AAPP was having a conference in Denver. And I want to say this is probably 2011-ish. Okay. So it wasn't in the beginning for us, 2009, it was 2011. And Garrison was going to that. And essentially we were like, hey, how about we buy you dinner? So I'll never forget it. We went to the Kevin Taylor restaurant in Denver. They had a little area down below that was kind of the let's call it like a wine cellar is what it looks like. And we had, I don't know, a 2 or 3 hour dinner and a couple of bottles of wine, and just, it was so good to let's say, find a friend that was calling what he was doing direct primary care. And of course, we'd done some research prior to all that. So realized that he had, I think at the time, maybe had interestingly, Jeff Bezos and Michael Dell, like Dell Computers, and maybe a few others, help him out financially. And so we figured, gosh, those are really smart guys helping Garrison out. And they're calling the thing direct primary care. And it's very similar to what we are doing. We should now start calling ourselves DPC. It is a little bit of the story. It's a longer story, but that's a little bit of the story. And I can't tell you how good it was to meet him. And then to also, not too long after that, David Chase started writing about direct primary care in Forbes magazine. And then David was kind of the MC at the first DPC summit, which was put on by the Family Medicine Education Consortium in St. Louis when Larry Bauer was running things. So Dave Chase was writing about this. So there were kind of a number of really pivotal, important pieces for us. To your point, it helped solidify what, some cowboys in Colorado were doing. And maybe it wasn't so crazy, right?
Well, tell us about then, when you're talking with Garrison, when you're seeing Dave Chase talk and write about DPC, and you already had this membership model, under your belt that you had, like you said, marketed to your own patients. How did you then remarket the direct primary care, that title specifically, to your patients, whether they were on membership or whether they were still fee for service?
Yeah, so you can imagine a lot of this is happening within the smaller community that we essentially kind of been in and known for years, right? So we had all the way back to the very beginning, right outside of residency, had been going to Chamber of Commerce meetings, had been talking to small business owners. So very much involved in the community. And part of that, remember, was around the time of the passage of the Affordable Care Act. And while we had hoped that the Affordable Care Act, which essentially had really good intentions in the beginning, but maybe kind of fizzled out in the fourth quarter with regards to insurance companies and their involvement in it, we had hoped that that kind of had been, let's say, a solution for primary care. But really what it was more and more people having like high deductible health plans and not really getting, let's say, better if or more primary care. That's my short synopsis on that. But so part of it was like, hey, listen, we understand you have this high deductible and you need to follow up with me with regards to your diabetes and your high blood pressure. And I know you're going to be out of pocket for those visits. So one option is you can join Nextera, pay a monthly fee. And then kind of over time, we'd say, this is called direct primary care. It's a model of care created by physicians that saw problems in the existing fee-for-service insurance model. And you pay a monthly fee. And again, we were setting numbers. Back then, it was $99. Like we didn't have a lot of books to read or places to go. So back in the day, it was like, let's just keep it under $100. And part of that was, if you can afford a cell phone bill, which few people had cell phones back then, not like it is now, but you can afford what we're doing. If you can afford your cable bill or your Quest bill or your Comcast, right? So that was kind of the idea. And through those relationships in time, we just realized that a lot of people, small businesses, didn't have any kind of health benefit for their employees. So that's where the light bulb went on for us. So, hey, maybe we should help start taking care of them. And so we say, hey, it's $99 and you, the employer that owns your company, you can decide how much of that you want to pay and then pull the rest out. Maybe you can even pull the rest out of their paycheck pre-tax. So that's how let's say the wheels started turning when it came to, we have an opportunity here to take care of employers in our town. And most of these were small businesses with less than 50 employees.
That's awesome. And that's what I was going to ask, in terms of the people who were joining on to your practice and to this new model of healthcare in the area with the ACA passing, like who was joining your practice? And so, because I know like now Nextera Healthcare is predominantly serving people who are getting care through their employers. And so, it's very interesting even back then how, small businesses like you're talking about were really understanding before having, the pandemic show people like really what is wrong with American healthcare. They were very open to, hey, like this totally makes financial sense and it makes medical sense for our employees. So I just love that, they were early adopters. Now, when it came to, I just want to take a segue here into Nextera, because I don't actually know the history behind Nextera Healthcare. And how did you come up with the name?
So there are a number of chapters. I'll give you a few of them. But one is our original name is Revolutionary Healthcare. That was, I think at the time I was listening to Muse, a band that I liked back in the day and still like a lot today. And they had a song called Uprising and things were a bit of a revolution. And that's what we were doing, right? Like that's where we were at. We had this charge and this was change. Some of it was to restore the way things should be in primary care. Others was to disrupt and innovate. So very early on, we also figured out, I can't recall, I think it was through our IP attorney that a gentleman by the name of Steve Case, who owned AOL.com, dating me a bit here, had a company called Revolution Health. So that's where we're like, okay, maybe we shouldn't go up against that from a trademark perspective. So that's where we hired a marketing company in the Boulder area, as well as a few other marketing companies to try to come up with a name. And at the end of the day, it was my wife, Deirdre, who came up with Nextera. And so for those of you that don't know, it's Nextera because we weren't happy with the existing era of fee-for-service medicine. So we wanted to create the next era of healthcare. So that's how Nextera Healthcare came to be.
Love it. And I will say, like, people, who are hearing the Muse reference and stuff, like, they also don't know about the DJing. So please do put a little bit here about the DJing before we go on.
So a buddy of mine, Scott, and I, it started in high school where we started DJing proms and homecomings, and that morphed into a little bit of college where we do house parties. And again, date myself here, like DJing did not used to be show up with your laptop and Spotify. So we literally would burn tapes with the Sony dual cassette recorders and make tapes. And we had literally albums. So our setup included, the Sony dual cassette. It included, we'd play albums and a lot of times, it'd be a 2 to 3 hour cassette taping. So we'd have to put a lot of time into that. And you have to think about the crowd and the different types of music and the genre you want to play. And then we had our light show, and it was all kinds of fun stuff in high school. And then around, 1988 or 89, the Sony 5-changer CD player came out, revolutionized what we were doing. And so, that was a whole fun chapter. But, that, like many of us, very into music. And for us, that actually has relationship to our company and how we named it Revolutionary Healthcare as we fast forward.
I love it. So, kudos to Deidre for coming up with Nextera. I love that, it's very forward thinking. It's still revolutionary. When it comes to, how Nextera as a company was set up, how did Deidre continue to be in the fold? And I ask that just because, especially like working with family members, like clearly there's lots of examples in DPC of people who are doing it, like Dr. Emily Scott and Dr. James Gore, who we both saw down in San Diego a couple weeks ago. There, Dr. Amy Ostick, Dr. Brian Ostick, there's another example. But how did you guys decide that both of you would be coming into the fold? And how did you set up roles in Nextera Healthcare with both of you?
Yeah, so obviously as a spouse, conversations happen. And in Deirdre's case, she has a background and expertise in business and marketing. And, you're bootstrapping things and wanting to make things work out. So a lot of conversations, right, about, hey, how can we do better? A lot of back and forth. And so fortunately, I kind of had this great sounding board, let's say, obviously there, let's say at a high level or so, there was a little bit of crazy. And it was always good to come back to her and have a little bit of grounding and say, what do you think? And to have those conversations, because we were really pioneering a new way of care here in Colorado. And she was very, very instrumental in that. Moving forward, as we were down a pathway, we needed help, right? And didn't quite go to Chase Bank and say, give me $500,000 and hire a bunch of people, right? You're bootstrapping things. And fortunately, was able to be in a circumstance where, my wife had a ton of expertise in business and marketing and could help. So that was super helpful, and I'm forever grateful for that. As we moved forward and our company kept growing and growing and growing, that, Deirdre's in a role where she's the VP of operations. So she, for years, has ran all kinds of things from HR detail to payroll to hiring, firing, et cetera, and really helps on the strategy front and helps on the marketing front. Granted, we have other people that help us handle the detail, but she helps with regards to the strategy on a number of those pieces. And it was that way years ago, and it's still that way, fast forward to today.
It's so cool because, again, especially with the both of you really, from the ground up, embodying what it means to be providing healthcare at Nextera Healthcare specifically. It's very cool to not have to, onboard someone and teach them the principles or teach them the values. Like you guys created them. So love it. Now, when it comes to, your opening statement, and you talked about how direct primary care really allows physicians to do the doctoring that they went to medical school to do, you have affiliates for Nextera Healthcare. So tell us about how did growth go from providing care in your community to providing options for people to become affiliates and still, practice under their own DPC flag as a Nextera Healthcare affiliate? And how does that work in terms of getting patients? Because it's not just in Colorado.
Yeah, so I think it's important to remember. So we started off with one clinic. This is back at a time when there was no DPC in Colorado, and maybe there was just a little bit across the country. And as we started having members sign up, or patients, right? We like to call them members. We were very much retail oriented. That was, let's say, the majority of our membership pie. As we continued to really have people join the gym, I mean, again, you can have a good idea, but then you have to have the strategy and the execution on that front. We're like, gosh, maybe we are kind of onto something. And it was kind of one piece after another, meeting Garrison, Dave Chase writing about things, just things moving in the right direction. The American Academy of Family Physicians bringing about 5 or 6 of us into this like think tank where we had a moderator for a long weekend because they wanted to really understand us and see how we're different than concierge medicine. like these pieces, you could start to see this evolution. And then, our first employer group signed up, small company, and this gentleman didn't have anything for his employees. And then, now he can offer this awesome benefit that actually puts him in the marketplace as an employer, puts him in a more strategic position, because now he can tell his HVAC technicians that, hey, listen, you can see these guys you want for your primary care issues. Granted, they're not insurance. They're not going to, help you with an ICU stay, but they're going to be your doctor. And so that was pretty cool for that owner to be able to pay for that. And then for those employees to have this really nice direct primary care benefit. And again, we had to explain this to them, right? They had no clue what DPC was. We're just saying, hey, you're going to get your physician. And literally back in the day, it's like, here's my cell phone number. And so through that, we got to get traction with, let's say, bigger employers and opportunities there. And our very first affiliates weren't DPC doctors, because there were no DPC doctors. Our very first Nextera affiliates were physicians that I knew, and guys like down in the Colorado Springs just great docs that I knew and trusted. And I said, hey, would you be part of this? And literally it was like a handshake at a Colorado Academy of Family Physicians annual meeting in Cheyenne Mountain Resort in Colorado Springs, right? It was like, would you come on board and we'll pay you per member per month as they come on to you. But for us to, let's say, put up a brand new clinic in Colorado Springs when we're an hour and a half north of there for only a few members, like financially, that would be very, very risky for us. So, we're bootstrapping it. So we're not going to put $200,000, $300,000 into a brand new clinic down in Colorado Springs. That being said, there are good doctors that were already down there that owned their own clinics. So for us, that was part of, let's say, the filter. Like, it wasn't us going to a large healthcare system saying, could you be part of what we're creating? It was us going to our friends that owned their own clinics. So kind of this goes all the way back to like Nebraska, like it's really important to have physician ownership and or physician leadership in medicine. And back in the day, years ago, a lot of physicians owned their clinics. It's just thrilling to me to know that we're starting to see, in one case, more of that courtesy of DPC. On the flip, less of that because big systems are acquiring primary care clinicians. So, interesting to see, let's say, that chess game, and all of us know what the better way is.
Amen. Amen to that. Now, when you started going beyond the handshakes with these friends who were, people that you trusted, you definitely expanded and, for example, to the state of Nebraska. And so tell us a little bit about how Strada Health came into the fold and how it became something that if you're a state employee in the state of Nebraska, you could tap into DPC.
Yeah. So as a Nebraskan, even though I've lived in Colorado for 20-some years, it bothered me that Nebraska had no DPC. And so Senator Merv Reapy, who I think previously was the CEO of Children's Hospital, Senator Reapy, just a phenomenal gent. And he had called me and said, hey, listen, I understand you're doing this DPC thing. I'm a senator in Nebraska, and we'd really like to pass some legislation here to make Nebraska even more friendly to direct primary care. So I said yes, and went back and he held a symposium for senators in Nebraska as well as businessmen. And in fact, I think the luncheon was at Blue Cross Blue Shield, which is unbelievably hilarious thinking back on it. And so we knew that there was going to be some legislation that was likely going to pass. And my old, essentially attending in medical school, Dr. Joel Besmer, who runs a tremendously successful concierge practice called Members MD in Omaha, Joel and I kept connecting, and mainly we were connecting through Concierge Medicine Today's forums. They'd have these conferences down in Atlanta, and Joe would speak on the concierge side, and then I would speak on the DPC side. So let's say through the evolution of that, and knowing that Nebraska was going to be, let's say, more open for DPC, we said, let's think about solving for that. And it was a lot of fun because about once a month I'd fly back to Nebraska, and essentially I would pitch the Nextera idea to employer groups, and Joel was taking care of the C-suite of these employers because they were part of his concierge practice. And so that was a lot of fun. And that's essentially part of how Strada was born. Let's replicate what has been working in Colorado with Nextera Healthcare here in Omaha. And fast forward to today, or to your point, through that process, well, first off, the legislation passed unanimously, okay? Democrats and Republicans passed unanimously. Number one, and Governor Ricketts at the time from the Ricketts family signed that into law. We were pretty excited about that. And through that came an opportunity to take care of the state employees. So that's a little bit of background on how the legislation passed, how state employees are able to get DPC, and then how Strada was created.
It's such a powerful example of how DPC can really be made accessible to everyday Americans, right? It's like you're a state worker. I mean, like I grew up in Sacramento. Everyone's a state where everyone's parents are state workers. Where I'm like, this is so sad, but it's like I didn't know actually what our parents did. They just worked for the state, right? And so it's like it's so awesome that everyday Americans could access direct primary care, and not just like you said, just those C-suite people who Joel was taking care of previously. So when we talk about law and where law can help, DPC be protected in certain areas, where, this interview is coming on the heels of Jay Keese talking about the 3 bills that are on Capitol Hill as of this recording. It would be amazing if things magically passed by then, by the time it airs. But, there are 3 bills, which is incredible, compared to bills about family medicine or primary care in general. These are DPC focused bills. Looking back on laws and DPC, tell us a little bit about Colorado and how Colorado came to have a DPC law, because there's other places in the states that do not have DPC laws, like Jay pointed out in his interview.
Yeah, so we in Colorado started around 2009, with the idea. I think we were finally seeing patients around 2010, 2011 that were Nextera members. And we moved forward with taking care of employer groups. And, fast forward to, let's say, 2016, understanding there were some changes happening at the federal level, we said maybe we should put a law on the books here in Colorado, even though we've been doing business for years. And part of what gave us the ability to, let's say, do that business and be pretty reassured is very, very early on, we met with the Division of Insurance here in Colorado. And I'll never forget it, because we said, hey, what we're doing is primary care. And she's like, you guys aren't going at risk. You're not an insurance company. Go do what you want to do. I'll never forget that. So we're like, let's go. Let's get members on board. Let's keep growing our business. And we don't have to worry about the Division of Insurance coming after us, thinking that we're somehow insurance. I mean, we're charging $99 a month. We don't have millions sit in the bank. We're not taking risk. So that's how we, and part of that was get membership, right? And then have friends in lots of places in case the boogeymen come out of the bushes at you. So that was part of our strategy. And then as we started into 2016, 2017, and then seeing some other states pass legislation, we said, gosh, maybe it is time here in Colorado. And, there are times where the DOI head can change, and there's times where the governor can change, right? So we, with the Colorado Academy of Family Physicians, so CFAP was tremendously helpful and supportive here. And we put some legislation through. There were those of us in Colorado that were DPCers, so we testified at the committee levels. That then passed unanimously. It went to the House and Senate and passed unanimously out of both the House and Senate. And then in that case, Governor Hickenlooper signed it into law and actually had a DPC signing day, which was unbelievable, right? So all of us DPCers, Dr. Lisa Davidson, myself, Dr. Bender, Dr. Mike Keller, went to the Capitol, and I'll never forget it because I also brought my 3 kids, and Governor Hickenlooper gave my kids a pen, essentially that he had signed that bill into law with. So I think it's just testimony to the power of direct primary care that here you have a Republican governor in Nebraska, and it passes unanimously, let's say in a more conservative state. Then you have Colorado with a Democratic governor, and it passes unanimously and signed into law. Essentially what these laws said was, we're not insurance, so therefore the Division of Insurance is not to regulate what we do. We already know that the law of the land, the Affordable Care Act, says that DPC plus a qualified health plan meets the requirements of the ACA. So we already have that federal law. And now you see, I think, over 30 some states that have these state laws. And then of course, we have some states that are laggards. That are still trying to sift things out. They're just laggards. And one of them I'm going to call out is Alaska. It's far past time that Alaska needs to get this done so the citizens of Alaska can have access to DPC, which they should have had that years ago. And there have been some hurdles in the way. But yeah, exciting to see the stuff that's coming out as a veteran. Gosh, I would love for vets to be able to have access to direct primary care in a way that's different than what it is right now, which right now they do have access. They pay out of their own pocket. I'd much rather it be that our government step up to the plate and pay the average $80 or $90 that it costs to join a DPC practice in this country for vets. You really want to change care, don't spend billions more on vet centers, spend billions on actually millions, doesn't need to be billions on direct primary care, and you're going to see a change in this country.
It's amazing, what bootstrapping with the right people and the right intentions can do. So love it. And when it comes to, the three bills that are on the Hill, again, as of this recording, none of those have passed officially yet, but they're making it through committees. And one of those bills that had passed through committee successfully in June was the Medicaid Primary Care Improvement Act. So again, another example of how bipartisan. Kim Schreier from Washington and Dan Crenshaw from Texas are the people behind this particular bill. When it comes to Medicaid in particular, I want to ask this because Colorado, versus other states, it is more restrictive when it comes to DPC and Medicaid patients. So what do you see as a potential for the Medicaid Primary Care Improvement Act helping Medicaid beneficiaries access DPC in Colorado?
Yeah, so a lot of thoughts there. Let's see if I can distill down to a few. Yes, you're correct that Colorado, I believe, is one of only two states in the country, Colorado and Kentucky, where a Medicaid recipient cannot pay a DPC doctor. So that blows our mind, right? And they should be able to. So you got to fix things to make that a possibility. Medicaid recipients all across the country are being underserved, just like hardworking blue-collar Americans that have high deductible plans are being underserved, just like people with fancy Cadillac PPO plans are being underserved, right? So there's lots of people that are underserved, and I mean very specifically, people that just don't have really good access. It's not convenient. They don't have a relationship. They don't have trust in their primary care physician. So that's a lot of Americans. So as we think about Medicaid, Medicaid is a tremendous opportunity. And we would love for there to be a lane where a Medicaid recipient could see a DPC physician and have that paid for by essentially the taxpayer, right? There's two people that pay for healthcare in this country. One is employers and the other is the taxpayer, right? It's not insurance companies. It's not the government. That's the tax dollar, right? So at the end of the day, how is the government spending our tax dollars? And gosh, it would be tremendous. I would love to have a clinic that serves Medicaid. I'd open that up in a heartbeat. And I'll tell you, years and years ago, the leader of the House here in Colorado, he actually had come to us and said, I'd love to run a pilot where there's a Nextera clinic right next to an FQHC. And I said, we'd love to do that, right? But this stuff takes a lot of time when it comes to the government and the processes and the movement of that. But I sure hope in my life that we'll see that because a lot of Medicaid recipients are being underserved.
Well, there's a lot of us, including myself, who agree with that. It definitely, if you have not listened to Jay Keese's episode, definitely take a listen to that because hopefully, we will see really big changes when it comes to legal Capitol Hill supporting DPC through law. So now when it comes to you being a national speaker, when it comes to direct primary care, you speak to patients, you speak to employers, you speak to, people who are business owners, you speak to people who are just in the business of healthcare. So I want to ask, what questions do you continue to get about direct primary care, whether it be to clarify what is DPC still, or whether it be, about the future of DPC in healthcare?
Yeah. So, part of that is kind of like, why should I do DPC? Right? Like people, whether that person is a patient or whether they're a business owner or a CFO, like why should I do direct primary care? And part of what we come back to them with is, are you as an individual or as an employer, are you happy with your healthcare? And are you happy with the amount of money you're spending? And that's a couple of questions we've been asking for years. And hardly ever do we get yes and yes, no matter what crowd we're in front of. Can you text your doctor right now and have your doctor respond? No matter what crowd we're in front of, like hardly ever do we get a yes to those types of things, right? So that's where we start to get at, well, okay, let's start to think about how we perhaps could improve your care, the access, the convenience of it, the connectivity. Let's talk about moving beyond just seeing your doctor once a year for an annual checkup. That is so old school. It is just, if you want to move the dial on your health and wellness and you want to get to optimal health, you don't go to the gym once a year. Like you go to the gym hopefully a lot. So who better to help you down that pathway than your primary care clinician? The problem is hardly any slice of America can get that right now through traditional fee-for-service primary care. And about half of Americans have high deductible health plans, so they're only seeing their doctor once a year. And I haven't met a DPC doctor out there, or even a primary care doctor in general, that doesn't want to help people with their health and wellness, right? That doesn't want to talk to them about their lifestyle, about their sleep. and their nutrition and their exercise and their emotional health, right? Like that's bread and butter primary care. And fortunately, in direct primary care, we have the time for that. Patients have access to us. We don't have the cost barrier because there is no cost when you come see us. You can see us face to face. You can see us virtually. And so we're changing the relationship that patients have with their primary care clinician, which truthfully right now is pretty low, right? It's kind of, if you look at on a scale of 1 to 100, or you just look at a net promoter score, or these different rating systems, like a lot of people just don't have a relationship with the physician and the healthcare team that can take care of 90+% of their needs. So that's what, we offer in DPC. And that's what truthfully many of us went to med school for back in the day, as we did all this training and went to residency because we really want to take care of people. And when you don't have access to the doctor and healthcare team that can take care of 90+% of your needs in a very affordable manner, now you're actually putting yourself in a position where that's a great risk, whether you're a patient or whether you're a CFO. And so the challenge isn't, when am I going to do DPC for me or my family or my company? The challenge is if you're not doing it, right? And so it's been years in this arena, and there's nothing better out there, right? Sure, there's full risk plans with Medicare Advantage, but that is a lane right now that who knows if that's going to be around in a few years because of what's going down. And it goes back to the beginning of direct primary care, where a lot of pioneers were in the existing system and said, hey, we can do better. We're at that place now. We're far beyond proof of concept. We're getting ready to participate in the second Milliman report that will come out that will further show the ROI and value of DPC. And just realize, I guess, as you think about, gosh, should I do DPC or not? What kind of value we're currently getting? And unfortunately, most Americans are spending a lot of money. Most larger employers are spending $13,600 per employee on average for a Cadillac benefit plan, and yet their employees don't have really good access to care. It's not convenient. It's not accessible. Yet that cost of that premium for the employer went up 6.5% from last year to this year. So, I don't think I answered your question directly or in short manner, but, people aren't happy with their care and they aren't happy with what they're spending. Who is arguably the best person in the world to help you with that? Dr. Mariel, or Dr. Amber in Blair, Nebraska, right? Like all these physicians, Dr. Matt Hayden out in DC, Dr. Eric Crawl down in Florida, like the list goes on. Like all these docs are out there, and we're in 50 states and have been now for years. And it's time you go find yourself a DPC doc.
And I love, I set you up there because I love how you answered that, especially because the majority of people are getting care through Nextera Healthcare or getting Nextera Healthcare through their employer. I love that, that's the type of stuff that you can say to a person who's joining as a member or their family's joining, or you can say to someone who is the employer or someone who is the person building the plan for the employer, because what you're saying there is so high level as to the impact that DPC can truly have. And like you referenced, the Milliman study, definitely, if you've not checked out the Milliman study, check that out. There's lots of data in that study that can be used, no matter if you're rural or urban or whatever, to prove that DPC is not just all, words and, fancy websites. Like we actually do make a difference in the pockets of people who are choosing DPC, and we definitely make an impact positively in their healthcare.
Even before DPC, we knew that primary care significantly impacts a person's morbidity and mortality. Impacts your morbidity, your mortality, and your spend, right? And you'll hear time and time again, a lot of us DPC docs talk about, hey, we're not only here to help you with your health, not just be sick care doctors, like we want to help you get to optimal health, number one, but number two, we're here to be a good steward of your pocketbook. And when it comes to writing orders, whether that's for an x-ray, whether that's for a CT scan, whether that's for an elective knee surgery, whether that's an order to go see a behavioral health specialist, et cetera, not only are we going to help you down that pathway and provide the right care at the right time, at hopefully the right place, right, for the right cost. Like these are just things that are bread and butter, everyday direct primary care. And it's not that we couldn't do those in fee-for-service medicine. We were trying. We were just in a model where the volume was so tremendous and the business of it was so messy that it was really hard to do all that we can do in full scope primary care. You look at DPC, you can do full scope primary care, and you can provide, a half hour to an hour to 90 minutes of time with a patient and really start to get into detail, and then write an order for Crestor and they get it mailed to their home, and we bypass traditional PBM because it's more efficient and more effective and affordable to get it mailed to their home, or we maybe even have the Crestor in our office, right? Like all these things that primary care docs do. We have the time to do it. We're super passionate about it. And you're right that with Nextera, as you look across our organization, again, we started with one clinic. Now we're over at 40 clinics in Colorado. We're over 100 clinics in 14 states. We're soon to expand even more so into the Pacific Northwest with a number of clinics. And the common thread here is these are all DPC physicians that own their own clinics, except for like maybe one or two. And those were like legacy fee-for-service docs in Longmont that are part of our direct primary care network here, serving a school district. As we think about employers, we've grown from taking care of companies of 5 or 10 to taking care of companies of thousands to taking care of the school district where my 3 kids have gone to school, which is 55 schools and 6,000, or I think, covered lives or so, to Fortune 500 companies. So we have Fortune 500 companies that have employees in multiple states that provide Nextera, and they pay 100% of the Nextera benefit for their employee, just like some of the smaller companies do. So whether you're a craft beer company or whether you're a satellite company with rocket scientists or a municipality, like DPC can really, A, provide a tremendous primary care benefit for you or your employees, but B, it can actually set you apart in the marketplace compared to other employers because you're offering such an awesome benefit for your employees. And this will not, break the bank. On average, it's $70 to $80 per member per month, right? Like this is not your typical $1,000 Cigna policy here in Colorado per month, right? So yeah, it's fun to see where it's going, and we're not done yet.
I love it. And, it's so important to hear that because in our culture post-pandemic, we had the Great Resignation and then people are starting to go back to work. But especially if you're standing out there with and we offer healthcare, that's amazing. Especially if you're a smaller business where people don't expect that they're going to find healthcare benefits at, a brewing company or at a hardware shop, a mom and pop store. So it's incredible. Now, let me ask you this, because with you sharing where the Nextera footprint is, there's lots of opportunities that people with lots of money, specifically like VC companies, are coming at buying out healthcare. For example, Amazon bought out One Medical. When it comes to you talking about how each of these DPCs are independent, they're just affiliates, they're getting the benefits of having an employees nationwide, you still continue to like you're in your office right now and you just saw patients right before this interview. What is it that drives you to continue choosing to be a family medicine physician in DPC versus hey, I built this thing, I'm going to sell it off? And what words would you say in closing for other people who are thinking about, if I grew my DPC to have multiple clinics, what are some things I should think about to continue being the doctor that I went to medical school to be?
Yeah, I would say we're having as much fun today as we did back in, let's say, 2009, 2010. I would say at a high level, there's less risk now, right? Comparatively, we've really figured out a way that works for the patient, which is the most important, right? A way that works for the physician and healthcare team. You don't want to design and forget about the healthcare team and physician. It's a way that works for employers in a way that works for communities. And it's so cool to see a lot of fun things happening that I wish would have happened a decade ago. Some of these fun things are everything that's happening with Health Rosetta, the things that are happening at the FAP level and the support of the DPC Summit. None of this stuff happens without a team of awesome, cool people, hopefully trying to row in the right direction. And we wish that a lot of these things would have been around 10 years ago, where we'd have benefits advisors calling us saying, we want Nextera in our plan, we're not going to do it any other way. And if you think about it statistically, there are 150 million Americans that get their health benefit through their employer, 150 million or so. Nextera is solving and wants to continue to solve for that. It takes a huge village to try and make that happen, right? And so part of this is, as we're going forward, we want partners to help us with that mission of the right care at the right time, the right place for the right cost, and the ability to expand. And part of that is we want to have more Nextera branded clinics. These are clinics that we own and run, and we employ the physicians and healthcare teams, and we'll continue to have more affiliates. The cool thing with what we've created, we're now the nation's largest physician-owned and led direct primary care community. And what I love about it is, your experience with where you live as a doc and the network that you have is different than what Dr. Hayden has in DC, and it's different than what Dr. Amber has in Blair, and it's different than what Dr. Eric Kroll has in Tampa, and with what he has going on there, right? Like, very organic, and we know the right orthopedic hand specialist, and we know who has a good behavioral health therapy company, and we know the right physical therapy group to send to. But then taking that a step further at Nextera, like, we're super familiar with the plan design that the employer has. So when I talk about advanced direct primary care, I'm talking about these kind of pieces where we are very familiar, and maybe we even help design the self-funded benefit plan with a innovative benefits advisor. We've helped design that, and we know the fine details of it. So that part there is it's care navigation. And primary care clinicians are typically pretty good at care navigation, but traditional fee-for-service doctors don't know a thing about the plan, typically, of the patient they're seeing. They don't even know what they're necessarily getting paid through a United contract. So in advanced direct primary care, we are very familiar with the employee benefit plan. We go to open enrollment meetings. We stand there and talk to the employees, and we, meaning administrators from our team as well as doctors, of saying, hey, we're not a vendor for your company. We're the physicians taking care of your company. So kind of a long answer to what you're getting at here, Mariel, but we want to continue to provide really, really good care to employer groups and the communities we serve. We are definitely open to retail members that just want to join, and we need more people to come and jump in the ship with us, and whether those are business people or whether those are doctors. So that is something that back in the day, when I came out of residency, I didn't have that opportunity, right? I could join a big system. I could maybe open up my own practice, which is risky, or I could join a multi-specialty group. Well, now you can join DPCs, and there are DPC docs all over the country that are hiring. Not every doc is cut out to run their own business. And maybe that's only 10% of us, right? So it's okay to not have to run the whole business. And we've got an awesome team here. And boy, I'd love for at least one or two male physicians to pick up the phone and give me a call. I just hired 2 female physicians, so we need another male or 2 to help join us. And I think maybe one of the last parts that comes up on your question is, yes, I have a panel of DPC patients that I see, and that's some of the most fun part for me. Is I just love taking care of people, and being involved as a clinician day in, day out better helps me remain focused on the business side.
With that, thank you so much, Dr. Flanagan, for joining us today.
Oh, such a pleasure, Mariel, and so appreciate everything that you're doing, not only in the community you serve, but for all of us across the country with my DPC story.
Next week, look forward to hearing from Dr. Philip Olshausen, formerly of Rogue Direct Primary Care in Medford, Oregon. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now, as well, as it helps others to find all these DPC stories. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC in the meantime, check out dpcnews.com. Until next week, this is Mariel Concepcion.